Hello all. So today we will be discussing about giant cell tumor. It is also known as GCT. So the other name for GCT is also known as osteoclastoma. It is also known as osteoclastoma. So now, so this occurs only in skeletally mature patients. That means almost after 18 years, like after 18 years. So the most common age of presentation is around 20 to 40 years of age. So it has more female preponderance, that is females are most commonly affected than males. So the location here of these tumors are very important because they always tend to be epiphyseal, but they can also go into the metaphysis. So that is why they are known as epimetaphyseal tumors. So the most common sites which are affected by the GCT are, the first is your distal femur, followed by your proximal tibia, then you have your distal radius, and then in spine also you can get GCT at the sacrum, that is the vertebral body of the sacrum. So this is the order in which the GCT location is there. So coming to the clinical features, the patient will most commonly have pain and swelling which is localized. So in around 10 to 30% of the patients, they can have pathological fracture, which is a very important finding you should note. And in less than 5%, that is around some 2 to 5% of the patients may have pulmonary metastasis. So coming to the X-ray finding, what you can see here is a epiphyseal lesion. So this is an epiphyseal lesion which is also extending into the metaphysis, and it is lytic. Can you see? So first we have finished. It is an epiphyseal lesion and it is a lytic lesion. Can you see the difference between the bone here and the bone here? It is a lytic lesion. And the other one is, it is expansile. So it is eccentric. The third point is, it is eccentric. It is not in the center, it is eccentric. Then what you can see is this expansile nature of this tumor. Can you see how it expands here in this image? So, and it also, the cortex is very thinned here, and it has multiple septations like things. So this will lead to the soap bubble appearance, and you can see there is no periosteal reaction elsewhere. So it is confined to the cortex. So these are the X-ray findings which you should remember. Then an MRI may be suggested just to rule out any soft tissue involvement, or just to differentiate between a ABC and a GCT, where ABC will have any blood filled lesion, but in GCT there is no blood filled lesion. On histopathology, you will see two types of cells. One is your mononuclear stromal cells, and the second one is your multinucleated giant cells. Can you see here? All these are the mononuclear cells, but here you also see a giant cells. So these giant cells have many nuclei ranging from 20 to 40 or 60. All these are multinucleated giant cells, and these are the mononuclear cells which are here in this stroma. So these mononuclear cells are very important because these are having the neoplastic potential. So, but the multinucleated giant cells are characteristic feature of giant cell tumor. So coming to the grading, they are graded by a grade known as Campanacci grading. Here Campanacci grading, there are three grades: grade 1, grade 2 and grade 3. Here in grade 1, you can see the lesion is within the cortex. There is no cortical destruction. The lesion is present inside the cortex and there is no cortical destruction. Whereas in grade 2, you can see the lesion, the cortex is thinned out. Can you see the thinned out cortex here? Yeah. And in 3, the cortex is breached here. There is no cortex here. So this is a differentiation between grade 1, grade 2 and grade 3. Why we need this classification is that for the treatment purposes. So grade 1 is the lesion is well defined and the cortex is intact. There is no thinning of the cortex. In grade 2, there is thinning of the cortex, and in grade 3, there is cortical destruction. So coming to the treatment, the most common the treatment of choice is whenever you see a GCT, you should proceed with, there is a different step. First, you should do a biopsy and then confirm whether it is GCT. And if GCT is confirmed, then proceed with intralesional curettage plus adjuvants. This is known as extended curettage. So what are the adjuvants that can be used? Some examples are, you can use phenol, liquid nitrogen and bone cement. So what does these adjuvant do? They destroy the residual tumor cells. So is wide resection should be done? Yeah, wide resection should always also be suggested when it is grade 3 or in cases of unresectable sacral tumors. Is there any role for denosumab? Yes. So what is denosumab initially? Denosumab is nothing but a rankle ligand inhibitor. So what this does? This will inhibit the osteoclastic activity. Thereby, it helps in preserving the bone. So it can be used in unresectable tumors, recurrent tumors or metastatic tumors. So then what is the complication of this GCT? So the complications are, recurrence is a rare complication. In 5 to 10% of the 5 to 15% of the patients, recurrence can occur after curettage, but pulmonary metastasis is very rare in this patients. Now, can we solve a few questions on this tumor topic so that you can get a deep understanding of what and how to apply this tumor topic? So the first question what we are going to attend is, which of the following is the most common site for giant cell tumor? So my suggestion is that I ask you to read the question once again to understand what the examiner is expecting from you. So here it is very simple and straightforward question. Here they have asked you what is the most common site. That is the first thing you should highlight. And then what you should say is, what tumor are they talking about? They are talking about the giant cell tumor. So as we discussed earlier, what is the most common site? Let us go through the options. They have given us distal humerus, distal femur, proximal tibia and proximal distal radius. So I think you all know what is the answer. So the answer for this question is nothing but distal femur. So the order of which the most common is distal femur, followed by your proximal tibia, followed by your distal radius, followed by your sacrum. Distal humerus is also a site, but it is not very common. So moving on to the second question, which histological feature is characteristic of giant cell tumor? So I want you to go through the options once again, and now let us understand this question once again. They are asking about the histological feature of GCT. So as we know, what is the histological feature? As we discussed earlier, yeah. So what is the answer? It is nothing but what you can see here. It is the mononuclear stromal cells, and you have your giant cells, multinucleated giant cells. So what is the answer for this question? The answer is numerous multinucleated giant cells with mononuclear stromal cells. So let us also rule out why not the other options. So this is also very important. So you need to rule out the other options also, so that you could be very clearly understanding why not choose the other options. So where do we see sheets of plasma cells? So these sheets of plasma cells are seen in multiple myeloma or plasma dyscrasias. Then small round blue cells. So where do we see these small round blue cells? Yeah, these can be seen in where? In Ewing sarcoma. So this is how you need to rule out the other options, so that it will be easy. Even if you are not able to come to a conclusion, you can just rule out two options and you can rely on the rest of the options. So it will be easy for you to understand and write the question. So moving on to the next question. Which of the following is the first line treatment for primary resectable giant cell tumor? So what is the question? Understand it. It is asking about the first line treatment of a primary resectable GCT. So what is the answer? Yes, the answer is intralesional curettage with adjuvants, that is bone graft or bone cement. So now we will try to rule out what are the other options and why it is not a answer of choice. So radiotherapy, it is not commonly used. It is not commonly used, but it can be used for unresectable tumors. So is chemotherapy an option? No. Why? Because it is not a malignant tumor. So the next option is wide resection and reconstruction. Yes, it is a line of management for GCT, but not for primary resectable GCT. It is used for unresectable or grade 3 tumors. So coming to the next question, which of the following drugs is approved for the treatment of unresectable or recurrent GCT? So now we are talking about unresectable or recurrent GCT. So as we already discussed, what are the options? We can go for radiation. Okay, but now here the option is not radiation. It is given some drugs. So the first drug is imatinib, denosumab, methotrexate and bevacizumab. So now what is the option? Yes, denosumab is the option. Why denosumab? Denosumab is nothing but a monoclonal antibody, which is a rank ligand inhibitor, which will prevent the osteoclastic activity. Okay, and resorption. So thus it helps in GCT. Okay, so where can it be used? It can be used in unresectable tumors, recurrent tumors, or the patients who are very morbid and can never undergo surgery, or patients whose surgery can cause significant morbidity. So now let us also rule out why not the other options. Imatinib is a drug which is used for GIST and sometimes in CML. So methotrexate is used in rheumatoid arthritis and osteosarcoma. So bevacizumab is a drug which is known as anti-VEGF drug, which is used in glioblastoma and colorectal carcinoma. So the next question, you read the question once. Which of the following is a typical radiographic feature of GCT? Here they are talking about the radiographic feature. So what are the radiographic features? As we already discussed, it is epiphyseal, eccentric, expansile, thin cortex leading to soap bubble appearance, and there is no periosteal reaction. So now let us go through the options. Onion skin peel periosteal reaction, no. Sunburst appearance, no. So there you have this option, expansile lytic lesion with soap bubble appearance. So this is your option. So popcorn calcification. So now let us discuss why not the other options. Can you see here? It is expansile, it is eccentric, epiphyseal, expansile, lytic, and soap bubble appearance with no what? Periosteal reaction. So now why not the other options? So where will you see an onion skin periosteal reaction? So onion skin periosteal reaction is seen where? It is seen in Ewing's sarcoma. So where do you see sunburst appearance? It is seen in osteosarcoma. So where do you see popcorn calcification? So this calcification is seen in chondrosarcoma, where there is this popcorn calcification due to collagen matrix mineralization. So by ruling out the other options also, you can come to a options. So can you see here? This is the onion peel periosteal reaction. Then you have sunburst appearance as seen in osteosarcoma. Then you have chondral calcifications which is seen in chondrosarcoma. So now your next question is, identify the lesion given in the X-ray and choose the correct diagnosis. When an X-ray is given to you like this, first of all, identify the location. So where is the location? It is in the epiphysis as well as in the metaphysis. So think of a tumor of epimetaphyseal. So this should be your first clue. Can you see here? Then what is the? It is eccentric. Can you see it is eccentric? So that is your second clue. Third, it is lytic. You don't see any other matrix. It is lytic. Do you see any periosteal reaction? No. So do you see any calcifications? No. So with all these epimetaphyseal, eccentric, lytic lesion, you can blindly say it is a case of giant cell tumor. So it is once again an easy question. They are asking you to identify the histopathological slide. So you can see here multinucleated giant cells and stroma of mononuclear cells. So it is a case of giant cell tumor. So when we are discussing about osteosarcoma, Ewing sarcoma and chondrosarcoma, I will give you the histological pictures. The next question. So the question is getting tough as it goes by. So the next question what we are going to discuss is, which of the following statements is false regarding the giant cell tumor of the bone? So let us read out the options one by one. So it is a locally aggressive tumor with a tendency for recurrence. It typically arises in the epiphysis and extends to the metaphysis. So pulmonary metastasis from GCT indicate malignant transformation. Denosumab is used in unresectable or recurrent cases. Here, when you have this type of questions, it is very important for you to go through the question repeatedly and get a hint of what they are asking in this question. They are saying, so find out the false statement. That is the main clue. So that means 3 of the options are true and 1 option is not true. Okay. So now, what is the option? It is a locally aggressive tumor. Yes, it is a locally aggressive tumor with a tendency for recurrence. Yes, there is a tendency for recurrence around 5 to 15% even after curettage. So this is a correct option. So this is ruled out. Then it typically arises in the epiphysis. Yes, and extends into the metaphysis. Yes, it is arising from the epiphysis and extends into the metaphysis. This option is also true, so it is ruled out. Then pulmonary metastasis from GCT indicate malignant transformation. Yes, pulmonary metastasis can happen, which is around 2 to 5%, indicates malignant transformation. This statement is wrong. Okay, so these are locally aggressive and it can also metastasize to lung around 2 to 5%, but this does not indicate any malignant transformation. So even if this patient is having pulmonary metastasis, it can be treated with drugs like denosumab. So even for pulmonary metastasis, you can treat the patient with drugs like denosumab. It does not indicate malignant transformation. Understood? So this is very important. So it can reduce the tumor size and it can prevent osteolysis. So the last statement, denosumab is used in unresectable or recurrent cases. Yes, denosumab is used in unresectable and recurrent cases. Therefore, this option is also true and it is excluded. So the only option left is this. So the correct answer is pulmonary metastasis from GCT indicate malignant transformation. Though it is a locally aggressive tumor, pulmonary metastasis can happen, but it can never go into malignant transformation. I hope you understood this question. So moving on to the next question. So the next question is, understand the question once again. They are asking which of the following is true regarding the giant cell tumor of the bone. So that means 3 statements are false and 1 statement is true. So what could be the answer? It is the most common primary bone tumor in children. It never metastasizes because it is a benign tumor. It commonly affects the diaphysis of the long bones. It consists of neoplastic mononuclear stromal cells and reactive giant cells. So now, tell me what is the options. So what we have to find? We have to find only one true option because rest 3 are false. So what is the one correct option? So we'll read the options one by one. So it is the most common primary bone tumor in children. So this statement is false. Why? Because the most common bone tumor in children is osteosarcoma. So GCT is very rare. GCT occurs only around 20 to 40 years and after skeletal maturity, that is more than 18 years of age. So this option is ruled out. So then it never metastasizes because it is a benign tumor. No, it is a benign locally aggressive tumor which can metastasize to lungs and the percentage is around 2 to 5%. So this is also a wrong option. It commonly affects the diaphysis. Never. It will affect only the epiphysis and it can extend into the metaphysis. So this option is also wrong. So you are left only with one option which says it consists of neoplastic mononuclear stromal cells. Yes, absolutely. And you have reactive giant cells. You have multinucleated giant cells. So this is your correct option. So the next question. Which of the following statements about giant cell tumor is true? Now, once again, we have come to a question where they are asking which is true. So, we'll read the options one by one. So malignant transformation is most commonly seen in denosumab treated cases. The second option is it exclusively occurs in the epiphysis and never involves the metaphysis. The primary neoplastic component of GCT is the multinucleated giant cells. Campanacci grade 3 is best treated with wide resection rather than curettage. So, whenever you are seeing a question like this and you know the answer, I request you to go through all four options so that you will be very sure of your answer. So, now can we break down the question one by one, options one by one? Yes. So, let us break down the option one by one. So, malignant transformation of GCT is commonly seen in denosumab treated cases. No, it is seen in cases where it is treated radiotherapically. So, this option is ruled out. Then, GCT occurs exclusively in the epiphysis, exclusively, and never involves metaphysis. No, this is also wrong. It includes epiphysis plus metaphysis. The primary neoplastic component of GCT is multinucleated giant cell population. This option is also wrong as the neoplastic component here is the mononuclear cells, mononuclear stromal cells. So this option is also wrong. So grade 3 is best treated with wide resection rather than curettage is your correct option. So then you have this question. A 28, it is a case scenario. So this is very interesting as it gives you more knowledge and more details of the case. So a 28-year-old female, okay, 28-year-old female presents with progressive knee pain and swelling. The X-ray shows a well-defined light eccentric lesion in the distal femur extending to the subchondral bone. MRI reveals soft tissue extension without neurovascular involvement. So the core biopsy confirms GCT. So after initial denosumab therapy, follow-up imaging shows dense bone formation at the lesion site. So what is the next best step? So this is a very interesting question. So here they said, if you read the question fully, they said it is a GCT. So don't waste your time trying to find what is the diagnosis. So if you want to find the diagnosis, it says a 28-year-old female. Here the age is fitting, the sex is fitting, then the patient is having knee pain, swelling, X-ray shows a light eccentric lesion in the distal femur, then the MRI reveals a soft tissue extension without neurovascular involvement. So what does this line say as? It says that the patient is having grade 3. There is soft tissue extension. That means the cortex is breached and the tumor is inside the soft tissue. So the core biopsy confirms GCT. So the patient is being treated with denosumab. So follow-up imaging shows a dense bone formation. So what to do? Now for GCT grade 3 what we do? We do a wide resection. But here the patient was treated with the denosumab and the lesion has consolidated and the cortex is thickened. So what we can do? So do you want to do a wide resection? No, we don't perform because it is consolidated. That is the bone formation is present, dense bone formation is there. Now the bone is, what to say, the lesion is confined to the cortex. So now what you can do? So you don't want to do a wide resection. So do you want to initiate chemotherapy? As we said, chemotherapy has no role in GCT. Then discontinue denosumab and observe for 6 more months before surgery. So this is not a wise option. Okay. So what is the only thing we can do? We can proceed with an intralesional curettage and bone cementing as a definitive management. So This is very important for you to understand. So these type of questions are very important, and it also covers all the topics. So few things which we left are, one thing what you should understand from GCT is your variance of GCT. Your GCT variance. So what all things that just look like GCT. So here you can remember by the mnemonic A, B, C, D, E, F, G and H. So is it easy? Yeah. So we'll just know what are these GCT variants. So ABC is your SBC. So aneurysmal bone cyst or your simple bone cyst is your closest variant of your GCT. Then you have B for Brown's tumor, C for chondroblastoma, D for desmoplastic fibroma. You leave E and then come to F is your fibrous dysplasia and non-ossifying fibroma. Then you have giant cell rich osteosarcoma. Then you have benign histiocytoma. So these are your GCT variants which closely resemble your GCT. So the take home is, so whenever a question is asked on GCT, you should remember these following things. So GCT, remember 5 E's. It is epiphyseal, eccentric, expansile. You have your soap bubble appearance, which on palpation will give you eggshell crackling. Then the treatment is extended curettage. So what are the other things? The common age group is 20 to 40 years, that is more than 18 years after skeletal maturity, most commonly seen in females. Then you have your distal femur, followed by your proximal tibia, followed by your distal radius, followed by your sacrum. Then can it metastasize? Yes, pulmonary metastasis is common and it occurs in 2 to 5%. Is recurrence common? Yes, in 5 to 15%. So histologically, there are two things you should remember. One is your mononuclear cells and the other one is your multinucleated giant cells. Then Campanacci grading, where there are 3 grades, where your grade 1 is your cortex is intact, your cortex is breached. Here the cortex is thin. This you should remember. Then coming to the treatment options. And one thing, the patient can have pathological fracture. Coming to the treatment options, for grade 1 and grade 2, you can proceed with intralesional curettage plus bone grafting or extended curettage. For grade 3, you can go for wide resection. So for unresectable cases, you can start the patient on denosumab. Your denosumab is nothing but your rank ligand inhibitor, which will inhibit your osteoclast.